The Goldman Rakesh Prize was established some number of years ago after the tragic death of Dr. Goldman Rakesh at Yale. And her husband, Dr. Rakesh, developed this prize. And every year the awardees change a little bit. The awardee this year is particularly, I particularly like to introduce because his research is actually quite similar to Pat Goldman's Rakesh, except he does his research in humans, and she did her research in monkeys. So let me tell you a little bit about Cam Carter. Cam Carter comes to us as the chair of psychiatry and human behavior at University of California, Irvine. He's a past PI of Centrix and of Centrax 3 different times. He's also the director of the UC Davis Imaging Research Center. He's been at the University of Davis since 2003. Cam is an awfully interesting person for many different reasons, but for one reason why is that he was educated at the University of Western Australia. So he comes from Australia, but not even from the coast that we usually think of, but from the western coast of Australia. He did his undergraduate work there, and then he got his MD there. After that, he came for his residency to UC Davis, right where he is now, the chair of psychiatry. He spent some time as an assistant professor at the University of Pittsburgh before he then returned to Davis. Dr. Carter focuses on cognition, general cognitive control, and cognition and health and diseases, much like the cognition stories we heard from Deanna Barch, and they have been friends and colleagues over the years. Cam was one of the people who began using fMRI along with cognition to investigate cognitive and emotional processing in schizophrenia. He looks at imaging plus other biomarkers of treatment response in early psychosis. Cam is the editor of the Biological Psychiatry, Cognition, Neuroscience, and Neuroimaging, which is a different one of the biological psychiatries than Dr. Barch is. He's also a deputy editor of Biological Psychiatry. When thinking of what his contributions are to psychiatry and what he may talk about today, he's really worked on understanding functional neurocircuitry of cognitive control in normal people. And one of the reasons for looking at in normal people is to understand the mechanism and find treatments for disrupted neurocircuitry in psychotic disorders. Dr. Carter may talk to us today about the evidence for his circuit in frontal, cingulate, and parietal cortex as a cognitive control network and its participation in psychotic disorders. He will talk to us. Dr. Carter, the title of his talk is A Cognitive Neuroscience Approach to Understanding Circuits and Symptoms in Psychosis. Dr. Carter.
Thank you, Carol. Well, thank you, Carol, for that generous introduction. And thank you, BBRF, for honoring me with the Goldman Rakesh Award. I am going to be talking to you about my work in cognitive neuroscience. And I wanted to start with this quote by Eric Kandel. This quote was included in the cover of the original cognitive neuroscience textbook that was published by Gzaniga and Mangin and Ivory in the 1990s, when cognitive neuroscience was a brand new field. And at that time, Dr. Kandel, who's been right about a lot of things, predicted that in the future cognitive neuroscience would become a central part of all neuroscience. And since that time, there's been a remarkable growth and explosion in both the breadth and depth of work in this field, as well as the development of some very powerful tools that allow us to measure and record activity in the human brain, and also, more recently, to modulate activity in the human brain. This has created a growth in our understanding of the neural mechanisms that underlie healthy cognition, the ability to perceive, to see, to think, to feel, to make decisions, to interact with others. And it's also provided us with a remarkable toolbox that is leading to rapid advances in our ability to use these methods to study the very patients that we're trying to help, and to advance our ability to offer them new therapeutic interventions. So Dr. Tamminger actually helped me by talking about, in her introduction to Dr. Bartsch's talk, about the focus, the growing focus on cognition in schizophrenia. When we think about psychosis and schizophrenia, we typically think about the more dramatic aspects of the presentation, hallucinations and delusions. However, it's well established that impaired cognition is present as a distinct and quite disabling aspect of schizophrenia. It's present even at the first episode, and it persists through the lifespan. And there's evidence that I'll show that it's present even prior to the onset of those positive symptoms. Another critical aspect of cognitive deficits in schizophrenia is that despite a lot of effort and investment, particularly by the pharmaceutical industry, our current available therapies have very limited impact on this aspect of the illness. Something that got me excited early on in my career was that it seemed like this was actually the low-hanging fruit for understanding psychosis, because unlike many other aspects of the disorder, we have tools to measure cognitive functions and mechanisms in the brain in an objective way. We don't have to rely on self-report or clinical interviews, and we can sort of prescribe the symptoms using experimental cognitive methods. And then, as I mentioned, we then began to develop the ability to incorporate all of that into functional brain imaging studies that allowed us to directly interrogate the circuits in the brain that are affected by the illness. This opens up the opportunity to develop circuit-level biomarkers that are related to the underlying disease mechanism. This is something that our former NIMH director referred to as circuit psychiatry. And I would suggest that through this approach, using these tools, cognitive neuroscience can provide a unique bridge that links cognition and brain circuitry on the one hand to the important clinical aspects of the illness, and on the other hand, it's a bridge to investigate the cellular and molecular mechanisms that underlie the pathophysiology of illnesses such as schizophrenia. So Pat Goldman-Rakish was a pioneer in cognitive neuroscience. As Dr. Tamminger mentioned, she mostly worked in animal model systems, particularly the awake behaving monkey, but her work was informed by ideas, theories, and methods from cognitive psychology. And cognitive psychology was the emergence of the interactions between cognitive science and neuroscience that came to us in the late 1980s and early 1990s. And Pat was absolutely a pioneer of this, with a focus on working memory in the prefrontal cortex. She also made the connection to schizophrenia. As a basic scientist, she was familiar with the fact that patients had cognitive deficits. She was familiar with the fact that the frontal lobes had been historically implicated in schizophrenia. She made that connection, and she began to collaborate with clinicians such as Phil Holtzman, Zoe Park, and others to do clinical research using those, initially the tasks that she had used in her non-human primates, and began to really begin to provide a modern perspective on impaired cognition in schizophrenia, and also that connection to the underlying neurobiology that we have all been seeking. I'll also say that I'm very grateful to Pat because I knew her early in my career. She was a supporter of my research. We talked a lot about the prefrontal cortex and working memory, and I feel very grateful that I'm honored by an award in her name. One of those exciting tools that we got access to in the 1990s, during the Pittsburgh phase of my career, where a number of other participants in this, we're maybe the second to WashU, you know, Pittsburgh. So it was functional MRI. So functional MRI is a method that takes advantage of the fact that when a part of the brain is working harder, there's an influx in perfusion and an increase in the ratio between oxyhemoglobin and deoxyhemoglobin. And this change can be measured using an MRI scanner, so that if you give a person a task in the scanner, you put the brain to work, you can make a kind of a slow motion movie of the living, working human brain. Blows me away to this day. It's a very, very powerful tool. And early on, we were able to do some interesting experiments that hadn't been able to be done before using event-related fMRI. We were able to use experimental cognitive tasks in what's called a factorial design and look at different elements of cognition that were engaged during different phases of the task and begin to break apart, at the level of the whole brain, functional networks and understand how different elements of those functional networks communicated with one another to dynamically support human cognition. So in some of these studies, in most of these early studies, we focused on this construct of cognitive control, the ability to use a goal, to use the intention to perform a task, to overcome habitual responses. In this case, this famous task is the Stroop task. You give somebody a colored word, and they're told, name the color of that word. But the word is also the name of a color, which is quite distracting and requires cognitive control. When we gave people a cue that asked them to engage cognitive control, we found that one aspect of frontal lobe circuitry, the dorsolateral prefrontal cortex, that you've already heard a fair bit of this morning, increased its activity. It ramped up when people were getting ready to do this tricky task. And the degree to which people could increase activity in the dorsolateral prefrontal cortex predicted how well they did the task, how good they were. Another element of the that circuitry that you've also heard a little bit about today, the anterior cingulate cortex, didn't really care what task you were going to have to do. But once you had to respond to this tricky stimulus, it increased its activity. And what we saw in subsequent studies was that the degree to which the anterior cingulate was active during the conflict that was elicited by this stimulus predicted on the next trial engagement of the dorsolateral prefrontal cortex again, and also behavioral improvements that happen after you respond to one of these tricky trials, indicating that this functional circuitry is adapting on a trial-by-trial basis, with one part of the system serving as an indicator that you need to engage the other part of the system in order to keep yourself on track. So a dynamic functional circuitry of a higher cognitive function, which we refer to as cognitive control. When we took this into clinical research, we were able to see in a whole series of studies, and this is one that involved young people with recent onset psychosis, about a third of whom were not on medications, that when they were given a cue to engage cognitive control, compared to healthy comparison subjects, the people with schizophrenia did not activate the dorsolateral prefrontal cortex to the same degree as the comparison subjects, and they didn't recruit this distributed network that was connected with the activity in the dorsolateral prefrontal cortex. And the degree to which that activation and connectivity was reduced in patients, they were worse at the task, they were clinically more disorganized, and in the community they were functioning less well. In a series of studies that were supported by an NIMH developmental center grant, we looked at the generalizability of this cognitive control deficit and its relevance to other cognitive deficits that are seen in the illness. And we looked, in addition to working memory, we looked at the role of cognitive control in long-term memory, memory encoding and retrieval, simple motor control, language comprehension, and emotional decision-making. And what we saw across a range of different tasks tapping into different domains of cognition were that when the cognitive control demands during those tasks were low, people with schizophrenia performed just as well as the comparison subjects. But when the cognitive control demands were increased, then schizophrenia patients started to show performance deviation from what's seen in healthy control subjects. And in studies where we had fMRI or EEG, where we could infer localization of changes in the brain that were associated with these behavioral changes, we saw that this was consistently associated with reductions in activity in the dorsolateral prefrontal cortex. In a range of studies involving patients, we have also shown, with regard to this cognitive control prefrontal cortex sort of disorganization syndrome that we see in the illness, that it's present in first episode patients, which I just showed you, but also in clinical high-risk individuals that you've heard a little bit about this morning, people who show attenuated positive symptoms or increased risk of developing the illness but haven't yet crossed the threshold into full psychotic severity. We also saw that, and have continued to see, that these PFC-related cognitive control deficits are also seen in bipolar disorder with psychosis, in addition to people with schizophrenia with psychosis. We've seen that they do not remit or progress during the early course of the illness, so we see no evidence of a degeneration that's going on after people present in the clinic, nor do we see an improvement, although we do see that in the patients, there is a developmental improvement that happens that's comparable to what's seen in controls, even though their overall level of performance is reduced compared to the comparison group. And also that impairment in this prefrontal cortex cognitive control brain system is predictive of poor treatment response, and I'll tell you a bit more about that in a moment. All of these findings together suggest to us that cognitive control and the associated disruption of prefrontal cortex that is related to this can serve for us as a neurodevelopmental biomarker, something you can measure that's related to the underlying cause of the illness that's associated with both psychosis and potentially psychosis risk. So to the clinical implications. You know, one of the biggest challenges in taking care of people with schizophrenia is that it's very heterogeneous, and this is reflected in lots of things, but in particular response to treatment. So these are three well-known individuals who publicly identify as having schizophrenia: Nathaniel Ayers, John Nash, and oh my gosh, Ellen Sachs, that's right. And so Ellen and Dr. Nash and Mr. Ayers have all meet criteria for schizophrenia. They qualify as having this diagnosis. However, their clinical course has been very different. And when we see people come to our early psychosis clinic, we have no way of knowing which medication a person needs, or whether or not they're even going to respond to the medications that we have to offer. And unfortunately, even with the very best of clinical care, in our early psychosis clinic, roughly 40% of the patients that enter the clinic at 1 year follow-up do not show a significant clinical improvement. They have gone through a trial and error process of trying to get them on medication. We offer them psychosocial supports and case management and other things to help them get well. But despite this, there's a quite high failure rate. And we have no way of predicting this. In fact, systematic studies have shown that experienced clinicians are no better than chance at predicting who's going to be a treatment responder or not. So we were interested in whether this biomarker related to PFC function could have a relationship to non-response. And so in my lab, Jason Smusny conducted an analysis of a large sample of patients who had come in and had fMRI prior to their enrollment in the clinic and were followed for a year. And what we saw was that the level of activation in this frontal parietal cognitive control network was quite strongly associated with the likelihood that a person would be a responder. So good prefrontal cortex, more likely to get well. poor prefrontal cortex function, likely to be a non-responder at 1 year. So somewhat akin to the work that we heard related to TMS, we're very interested in trying to use the tools that are now quite mature that we have to interrogate some of the underlying pathophysiological mechanisms that are present in psychosis, to develop decision support tools that would allow us to better predict who's going to be a treatment responder and who is not, and also perhaps which kind of medication would be the best for an individual. So in a study that's being led by my colleague Ian Davidson, who's a computer scientist at UC Davis, we're developing an AI tool that can take input related to, that is acquired during a single session of MRI that includes this fMRI-based measure of prefrontal cortical control functions, as well as an MRI-based measure of dopamine. This is neuromelanin imaging. People who tend to be treatment non-responders also tend to not have excessive dopamine activity in their brain compared to people who are treatment responders. That kind of makes sense because our medications are dopamine-blocking drugs. And this has been shown using PET imaging. We're using neuromelanin, which is the more scalable way of studying dopamine function, and putting it into this predictive algorithm. And we're also using a mechanism of neuroimmune perturbation or neuroinflammation that we get from diffusion-weighted imaging. So I'm going to very quickly tell you two avenues that we have pursued to bridge in the other area, to bridge from cognition and brain circuitry to the underlying cellular and molecular mechanisms that form the pathophysiology of schizophrenia. So one of these studies is housed in our Conti Center, which is still housed at UC Davis. This project is motivated by the fact that one of the strongest non-genetic risk factors for schizophrenia is maternal infections during pregnancy. So women who have a significant infection towards the end of the first, beginning of the second trimester are 4 to 7-fold more likely to have an offspring who 2-3 decades later will develop a psychotic illness. And this is known to be unrelated to the effect of the virus directly, but instead is related to the immune response that the mother has to the infection. And so in this Conti Center, we have a unique animal model system, which is a macaque monkey, and I'll just sort of step across to the actual design. So the macaque monkey has a challenge to its immune system, timed to correspond to the window of risk for humans. And that monkey gets well quickly and delivers an infant that is essentially healthy and normal up until roughly age 2, where the animals begin to show subtle cognitive and social deficits that are measured using tasks that are similar to the ones we use in patients and can be interpreted in terms of this cognitive control construct. But interestingly, they also have longitudinal imaging studies, and as early as 6 months of age, which is sort of equivalent to about 2.5 years of human age, these animals have reductions in frontal cortical volumes, and they have evidence of an increase in this inflammatory biomarker that's also present in our patients, and the degree to which this biomarker is present is strongly correlated to the level of the immune response of the dam. I see Dr. Tamminger here, indicating to me that I've used up most of my time. So I'll just summarize here by saying this is a powerful non-human primate model. It's interesting because you made the connection to PAT, and I have found myself using that model in some of this more big science research that we've been able to conduct in recent years. I think it's a very powerful example of the robustness of this model and its validity as a model of altered neurodevelopment that's relevant to schizophrenia risk. And I also think that it testifies to the potency of the cognitive neuroscience approach, where we can center our research around our clinical disorders and we can use common concepts and common tools to gain insights into the potential underlying mechanisms. I was going to show you some genetic data, but I won't, I don't think, right? What I'll do instead is I'll just skip through. You can ask me about the genetics and finish with this point again about cognitive neuroscience, which is that the tools and constructs of this field provide us with a unique bridge. It links cognition to brain functions and symptoms on one side, and it links cognition and brain circuitry to potential underlying cellular and molecular mechanisms on the other. And then I'll just go ahead and I will thank you for your attention. I'll thank BBRF for this honorific award, and I'll be happy to take any questions if I have any time.
We'll have one or two questions. And I have one. Oh, maybe you and I can compete. Let me just get mine first this
This
time.
one's going to be back closer.
Heterogeneity is rampant in schizophrenia.
Yes.
How does cognitive control help with reducing the heterogeneity?
Well, I think that it can help us understand some aspects of the heterogeneity. So I think it can explain to some degree why some people are really disorganized. Some people with psychosis are really disorganized and have trouble functioning, and how others are less so, because there's individual variability within the population of people with schizophrenia. I think that's one way that it can do that. Another way is that it can help us understand the individual patient's likelihood of getting a robust treatment response to sort of treatment as usual in early psychosis care.
And I'll ask you to make it short, but go ahead.
This one's for you also, so you guys can work it out. You and Dr. Keshavan have been looking at the biotypes, development in terms of schizophrenia. And, he's pointed out that there are certain biotypes that may predict early treatment response or a very poor treatment response, similar to, your patients that had poor cognition. For instance, people that have had a clear long-term neurodevelopmental process, some learning disabilities, poor cognition, typically don't respond to the typical neuroleptics and only did better with clozapine. So that's point one. Point two is the lack of evidence for anything that we have that improves cognition. The evidence is not strong, but Cobenfy is a drug potentially there, but more importantly, clozapine has some evidence. And if you go back to Lieberman's study and you look at the first 12 weeks of using it in the first episode psychosis, the study where he took the patients in China and randomized it against thorazine, there was very strong positive cognitive benefits. It didn't pan out at a year, but there was also about 50% compliance. So I just wanted you guys to work out that. I think there was a question in there somewhere.
Let me just mention that there's a new drug for the treatment of schizophrenia these days that was approved on the 26th of September and will soon be available for use. And one would wonder what the effect. This drug was not developed as a dopamine receptor antagonist, and it was really developed as a cognitive enhancer. And one would wonder what this muscarinic agonist actually would do in your cognitive control.
Yeah, so there are a couple of studies related to the new compound that offer a hint, a whiff, that at least people who start off being cognitively impaired may do better with that drug. We've seen this before with many new drugs. So far, you know, the cup has tended to be more half empty than half full. But I'm hopeful, optimistic. It would be wonderful if we had a drug that would be helpful for impaired cognition and schizophrenia. It would be a part of our toolbox that we're really badly missing at this point.
A redaction. In the study that I referred to, Lieberman's study, he actually looked at the treatment effect, whereas the treatment effect, looking at the PANSS and SANS index, was about 0.58 to 0.62 with cobenfy. It was well over 1.5, looking at similar indexes with clozapine. So I was just mentioning cobenfy to be kind, but
This will have to be a discussion. This will have to be a discussion over lunch. I can tell that we don't have enough time.
Yeah, all right. Thank you, Carol.
Yeah.
Yeah.
I'm going to turn.